Tigerlily's founder and president and CEO, and a proud 18-year TNBC warrior, thriver, survivor, and unicorn. Today's webinar is really important to me, being a woman who learned to have cancer at a young age, who had aggressive cancer, and frankly, after this week's events, I'm just even more impassioned about the things that we need to be able to see in the world to have equity for people who look like me, who are Black and brown. So we're going to just jump into it. I have some amazing guests with me today on the webinar. Deneen, Kirsten, Vanessa Shepard, Dr. Shepard, and Tamika Johnson, who's a dear friend and a wonderful, wonderful human being. So everyone, thanks for being here today. We're just going to jump in and have you all share who you are. I always say my patients are my VIP. Tamika, so please share who you are, because you're the MVP, because you're amazing, and you're one of the whys we're on this webinar today and doing this important work. Oh, Tamika, you're muted.
I apologize for that. Hi, everyone. My name is Tamika Johnson, and I am an angel advocate and a 3-time cancer thriver. I was initially diagnosed with cancer at the age of 13 with osteosarcoma, which is a form of bone cancer. It was cancer of the femur. I was then diagnosed at the age of 31 with breast cancer. And then at the age of 36, I was diagnosed with stage 4 breast cancer. My cancer had metastasized. I am also a mother to a 17-year-old high school senior, and she is my #1 caretaker and my #1 advocate. She helps me with everything. So, you know, that's my baby. She's been with me on this journey since she was 6 years old. So she also knows a lot about what I'm going through. And I'm an advocate, which I love advocating for breast cancer in so many different ways through clinical trials, trying to help people understand or help thrivers and survivors and fighters understand what the importance is behind clinical trials and joining the clinical trials. So I've done so much, and I will continue to do the work here with Tigerlily.
Tamika, you're really amazing, having had cancer for most of your adult life and young adult life, and seeing you in this advocating, being such a badass boss, and having your daughter be involved in the work, it truly inspires me. And thank you for all you're doing in this space. And thanks as well for being your support, being so strong.
Thank you so much.
Thank you, dear. Dr. Shepard, would you share a bit about your background and why you do what you do and why it's important to you?
Sure. I don't think it's by coincidence that we're here today, right? And so I think this is important. I am a researcher, so I focus on cancer care delivery, focusing a lot on breast cancer, specifically breast cancer disparities that women of color face, African American, Latino, African-born women. So that's a big part of my day job. Another part of that job is working to educate and disseminate accurate information in communities so that communities can be informed about how to advocate on behalf of their families. So happy to be here. I'm a scientist, I'm a soldier, and I'm also a survivor. This is 10 years for me from TNBC, right? And 30-something from Hodgkin's. Right. So never thought I'd end up in this space. Most of the time I show up as a scientist, but today I'm kind of showing up as my whole self because we got to bring all of this to it to make sure that populations that we care about can get what they need. So
really, this webinar today is, to your point, not by chance. I was telling my team earlier, I don't know if I could do this webinar this morning because it's been so much going on since the election, and as people who face such challenges in healthcare, who are patients and providers and advocates, thinking about the impact of that on Black women in our healthcare and just being a woman in general, right? So let's bring our heads and hearts to this talk today and be authentic and let it drive our messaging home to those who are watching. Thank you for that. So Deneen, your background.
Hi, everyone. My name is Deneen Saccone. I am Vice President of Policy and Advocacy at Cancer Support Community, which is a small nonprofit that provides free psychosocial and emotional support services to everyone impacted by cancer, patients, caregivers, and survivors. And I lead the Cancer Policy Institute. So I work with other patient advocates like Tigerlily and federal and state lawmakers to ensure that the voices of all people impacted by cancer are included in policymaking. And a lot of the work that we do, not unlike Tigerlily, is grounded and rooted in health equity. We want to ensure that all people impacted by cancer have equal opportunities and opportunities to receive the services they need to best support them. So that's who I am professionally. I have a passion for the work that I do personally. I lost my mom to breast cancer when I was 22 years old. My mom passed the day after I graduated from undergrad, and so she wasn't able to be there for my graduation, but I was able to make it home in time for her to know that I graduated before she passed away. And so seeing how aggressive her breast cancer was, we found out in May and she passed that December, just put a spark in me that I want to do all I can to support all people, all women impacted by cancer. So I do a lot of this work in honor of her and just hope that she's smiling down on me and I'm making her proud. Thank you.
That's beautiful. That gave me all the feels, Deneen. Thank you for all you do for your mom. I know she's here and she's smiling. I would be if I was your mom too. So thanks for that. And she is Deneen. I love that, Christina. Thanks for that comment. Kirsten Axelson, which I know your name very well. Can you please share a bit about yourself and why you do what you do and why it's so important to be in this space?
Thank you, Mayma. You're extraordinary in many ways, but being able to pronounce my first and last name puts you in like a very small subset of people who can do that. So I really appreciate it. And what an honor to be here with this group of women today. And so I trained as an economist, and I've worked in and around the biopharmaceutical industry for 24 years. And where the money flows is how we get treated in our healthcare. And I've really spent my career helping companies figure out how their patients are going to be able to access medicines, how the way that health plans make their medicines available to them will affect whether or not people get a certain types of treatment, how physicians are paid will affect how people get certain types of treatment. And then, most recently, spending a lot of time helping companies and patients anticipate how changes in law might affect what their access to treatment is. Because it's not just your doctor's decision, it's also what your health plan decides, or what is available to your doctor, what medicines are available. They've had huge issues with critical medication shortages, and so that's what I have done professionally. Personally, my connection to cancer is my grandmother, who was my late. She was a financial liability copay for their drugs. There are other parts of the IRA that create distortions in a system that, while flawed, was working quite effectively for a number of years to expand access to treatment for seniors and disabled people who get their health care through Medicare. When you poll the vast majority of people in Medicare, they're happy with their coverage. It was failing certain types of people, in particular people who needed high cost medicines, and those are the wrong people to fail. And there are parts of this law that will really help those people, but there are also parts of this law that will tend to make access to medicine harder. And I'm going to go through why I believe that is likely to happen. Just as some background, today Medicare Part D is administered by private insurance companies. It is a fallacy that there's no negotiation in Medicare. The private insurance companies negotiate on behalf of millions of people. In fact, they often have more people than like the country of Germany, let's say. So when they say other countries negotiate prices, the government has done this traditionally through health plans. And in fact, the discounts on drugs have been coming down over time, particularly in drugs that have competitors and alternatives, which is not all drugs, but it is many of them. The Inflation Reduction Act, among other things, directs the government to set the prices of 10, then expanding up to 20 drugs over time. And every year it will accumulate. So there will, at a certain point, be hundreds of drugs with government price setting. The IRA was developed quite quickly, and it's being implemented very quickly. And which is why I think there are some really necessary fixes to a law that, again, was developed and implemented quite quickly, and the timelines are quite intense to get it done. In particular, when you think about who's going to be affected by this law, it's older and disabled people who get their coverage through Medicare, and it's the higher cost treatments, which tend to be a lot of the cancer medicines, as well as medicines for rare diseases, Alzheimer's. We can go to the next slide. So, kind of just some background on Medicare before the IRA. There had been slow prescription drug costs on average. The net price had declined actually from $57 per prescription to $50 by 2018. That's largely due to the proliferation of generic medicines and health plans encouraging people to take generic medicines. That is on average. Not everybody can take a generic medicine. Again, there are some fixes in this law that are needed to especially address people who have high healthcare needs. Premiums had not grown very much. They were $2 more in 2023 than they were in 2007. Deductibles had been increasing and out-of-pocket costs have been increasing. That is particularly concerning for people who are on a fixed budget who don't qualify for the low-income subsidy. Importantly, and this is a big motivator for this fix, is the government's liability had increased markedly, in large part due to the proliferation of specialty medicines that tend to be higher cost. Next slide. So the government will intervene in a certain number of drugs to set the price, as I'll get to in just a few minutes. That doesn't necessarily mean that people who are taking those drugs will save money, but it will, to a degree, save the government money. It's a significant departure away from the original design of the IRA, which was intended to have competitive negotiation, and the plans would negotiate with the drug companies directly to bring down prices. This interference in the competitively negotiated program will save some money on the one hand, but will also affect the private sector actors who have been developing the treatment, and also the likelihood that health plans will want to participate in offering a drug benefit. Next slide. So just for some context, Medicare is roughly 28% of the U.S. Spending on drugs, so a pretty significant chunk of it. While the government is setting the prices for a relatively small number of drugs, the law affects all drugs in different ways, and I'll explain what part of that is change to the subsidy structure, but also because companies do not know whether their drug will be affected or not by the price controls. And you don't know that when you're developing the drug, you don't know that when you're deciding to study it in a second or third or fourth cancer indication, but every additional study that makes the drug bigger, meaning more expensive to the government, puts you closer to that region where you would likely to be selected by the government for a price control. So if you've already got a drug that's developed for 2 types of cancers and you're thinking about developing it for another, but once you do that, the government's going to set your price and bring the price down by 30 or 40%. You may decide not to do that additional study because it just doesn't, financially make sense to engage in that clinical trial. As I said in the beginning, it is the unfortunate reality of healthcare that where the money flows affects what gets developed and what is available to people. In addition, the U.S. is 40% of the global market for drugs, closer to 50% for oncology and specialty medicines. So what happens in the U.S. affects what's developed for the entire world. And it's just simply not the case that other parts of the world will make up the difference, because they don't. The U.S. does subsidize the rest of the world's drugs. I think that's part of the way our system has been designed. The U.S. also gets faster access to medicines and has more access to medicines than any other country in the world. Next slide. So quick overview of the Inflation Reduction Act. It requires manufacturers to pay a penalty if their drug prices grow faster than inflation. It limits the out-of-pocket costs for certain drugs limits the out-of-pocket costs in Medicare Part D to $2,000. It redesigns the Medicare drug benefit and puts more responsibility on it takes responsibility away from the federal government and gives it to health plans for high cost people. Originally, the federal government had taken on a lot of the responsibility for high cost people because it didn't want the health plans to set up benefit structures that avoided high cost people, such as people with cancer. Again, that's why I have the concern that as the health plans take on more and more of that responsibility, will we start to see formulary structures that discourage people from selecting the plans who have high cost conditions like cancer. And then it mandates direct price setting for a select number of therapies that have the highest revenue in the Medicare program. That should be a 2026 or 2029 on that last. That's when that is first implemented. Next slide, please. So then, thinking a little bit about how this is going to affect insurance plans, that previous slide talked a little bit how it affects patients. We should care about how it affects insurance plans because they are what decide what our drugs cost. They decide based on the formulary access and what they're going to put in terms of a copay or cost sharing. We're likely to see higher lunch prices going forward into the future because of the limit on price increases. We're likely to see health plans put in more formulary tools, more limits on formulary access because now they're taking on more of the responsibility of higher cost people. And we will see within the drugs that do have price controls, price is negotiated by the federal government, those prices will come down. That does not necessarily mean that there will be savings passed on to the beneficiary. If we go to the next slide. I'll talk to you a little bit about why I believe that to be the case. The process CMS will use is to select from among the biggest drugs in Medicare. Some of those drugs are among the most deeply discounted already, who have very good formulary access. The majority of people are paying a set $45 for those drugs, which is still a significant amount of money, but they're on a third tier, a preferred formulary tier without a lot of restrictions. Then CMS basically gives the drug company the price offer. The drug company can say yes or no, but if they don't accept the price, ultimately there's a penalty that is really financially ruinous. It can be more than 2,000% penalty of the revenue. So no drug company has yet said that they don't take the offer, and I suspect that will never happen. And then the government publishes the maximum price, and that becomes the price that has to be offered to Medicare, as well as the 340B program, which that can be another day's discussion. Next slide. This is the timeline, so we will find out in the first quarter of next year the rationale. CMS releases the prices and then will tell us what the rationale for those prices were. We'll learn why they decided to set what attributes they found important in different drugs. And then another round of drugs will be selected for price setting. There's a $3 billion budget set up for this process, and I will tell you, because I work with a lot of pharma companies, a lot of effort is spent on these negotiations with CMS, which are not really a negotiation because of the penalty, and very little information so far has been released about how CMS sets the prices. Moreover, a lot of things are asked of companies to provide that really don't have any meaning to patients, such as the manufacturing cost and the R&D cost. I think we could be doing more to do value assessment that would be meaningful to patients. Next slide. These are the drugs that were selected. I think I'm running towards the end of my time, but I'll go quickly through. As you see, some of them are used by millions of people and have lower annual costs. I realize $5,000 is still a lot of money, but that is not to the patient. That is a combination of what is spent in the premiums as well as in the cost sharing, such as the copay. And then some of the drugs have smaller numbers of patients and higher prices. Many of these drugs already had discounts on the order of 60 or 70%. So the net savings to the federal government they've announced is $6 billion. Many economists, including myself, don't actually agree there's going to be $6 billion of savings to the federal government because these drugs were so significantly discounted before the government stepped in, and other discounts are going to go away because the government has intervened in pricing. There is a huge focus in this first round on diabetes and cardiovascular disease, both diseases that disproportionately affect Black people and have worse health outcomes. I have a lot of concerns, particularly in the cardiovascular disease space, with the government setting the price for two of these drugs. Will we have generic entry? Generic entry is the most important thing for making drugs affordable at the end of their life cycle, and these drugs are close to that. And so I think there could be some long-term consequences in lower cost drug availability. Next slide. I'm going to go ahead. I think I've already spoke to a lot of this, so I'm going to go ahead and go to the next slide. So just thinking about going forward, oncology drugs represent 26% of the drugs that are projected to have a price set next year, in 2027. Of course, that is good in that the prices of those drugs will come down, which can be a benefit to patients. However, with the out-of-pocket cap, people are going to spend no more than $2,000 for drugs that are covered on their formulary, whether there's a government price control or not. Again, what I would be watching out for is with the government price controls affecting these small molecule drugs relatively early in their life cycle at the 7th year? Are we going to continue to see that same type of investment? Because a lot of the investment in cancer drugs happens late in the life cycle. That's when you study drugs in other types of cancers. That's when you study them earlier in the life cycle of cancer, which is when we hope to be able to address more and more cancers to increase longevity. That's also when you tend to see the pediatric studies. So it's a concern for many of us that if you are basically cutting off the profitability of a drug kind of midway through its life cycle, are you also cutting off the investment in clinical study, which has been so important to increasing cancer survival? Next slide. So, I think what we're going to talk about in this conversation is what are some of the key implications. We need to be keeping a close watch on the formularies. I'm actually leading an effort that is doing that, and I hope others of you are as well, to see if we're going to see drugs being more restricted. Remember that out-of-pocket cap is for the drugs that are on your formulary. If your drug is taken off the formulary and you have to go out of network, that's you're not protected by that out-of-pocket cap. And now we're going to see certain types of utilization management that is not clinically justified, but that is more cost-focused. We're also already seeing plans drop out because they are concerned about their new financial liabilities. Lower access to plans means lower choice of drugs, and that also has implications for patients. I believe that is my last slide.
Very well.
All right. Hopefully I did my 10 minutes.
You did a good job. Later on, I want to people are on now who are have breast cancer and who may want to hear a layman's version. I get it, but those who are on may not understand what it means in 2 sentences. Maybe later on during Q&A, share a bit more about what that you just shared in 10 minutes means to the average patient that doesn't understand these policies. So thank you for that.
Thank you.
I call on Deneen now to share about the ORPHAN Cures Act and the EPIC Act and what those means for patients.
Yeah, absolutely. Happy to do so. So I think Kirsten did a wonderful job, as usual, outlining what some of the issues are as it relates to a patient perspective with respect to access and affordability to these medically necessary medications. And so talking about clinical value, that was one area that she mentioned on her slide that CMS considers as part of the drug price negotiation program. What we did at CSC really quickly is we developed some patient-centered principles to work with CMS with respect to building a system as they roll out the drug price negotiation program that does not impede innovation, but also acknowledges and responds to the diverse and evolving patient experience. We want to make sure that the patient advocacy community, that we have a voice together in this discussion with respect to how clinical benefit is designed, because we believe that piece of the drug price negotiation program that Kirsten talked about, that's really where we can have some meaningful patient engagement, where we can talk about what are our care preferences, what do we want to see on a medication with respect to our quality of life, what does value mean to me. And we think that whatever CMS does, clinical benefit has to include the patient voice. And so with that, we worked with the patient advocacy community and aligned on some patient-centered principles to kind of help inform that definition and work with CMS as they build out this drug price negotiation program. And I'm not going to go through all of the principles. I'm going to share what those principles are. If anyone is interested in seeing how CSC, along with the patient advocacy community, kind of aligned on what we think is necessary with respect to ensuring that the patient and caregiver voice and perspectives are included with respect to drug price negotiation program. One thing I will highlight is that we definitely said it is important to consider groups and populations that have not already engaged in defining clinical benefit and the impact of the drug price negotiation program on their access to being able to receive services to not exacerbate existing health disparities. That's an area that is extremely important to us. And so with that, I do want to share that having these patient-centered principles as our foundation, there are actually some pieces of legislation that I'd like to talk to you about that we believe actually preserves patient access to medically necessary treatment and keeps the patient perspective at the center as it relates to innovative treatment options so that patients impacted by cancer can have as robust as a regimen as possible to treat their needs, because we understand that patients are unique. Patients don't respond to treatments in the same way, and patients have different and individual experiences, and those need to be honored with respect to how the IRA and other pieces of legislation that impact patients are developed. And so with that, I'd like to talk to you about two pieces of legislation that we believe are patient-centric. One is the Ensuring Pathways to Innovative Cures Act, that's the EPIC Act, and the other is Optimizing Research Progress, Hope, and New Cures Act, ORPHAN. So just remember these two. EPIC Act and ORPHAN Cures Act, we believe that those are the prime examples, two prime examples of how patient-centered engagement can ensure patients continue to have access to critical treatments now and in the future. And so a lot of the work that we do at CSC and as a patient advocacy community is grounded in evidence, it's evidence-based, and it's evidence-informed. And so one of the reasons why we support both pieces of legislation is that there are data out there, data that Kirsten does and other groups as well. For example, there was an issue brief released in 2021 by the University of Chicago, and their model estimates that the IRA price negotiations that Kirsten just mentioned could actually cause a $663 billion reduction in private research and development spending in the oncology space alone between 2022 and 2039. And what that translates to is there could be approximately 135 fewer new cancer drug approvals. And so with that, I'm going to talk to you a little bit about how these two pieces, the EPIC Act and the ORPHAN Cures Act, aims to preserve that innovation in the space and also aim to keep that access to care for patients and their loved ones. So the EPIC Act, the first one I mentioned, addresses a provision that we refer to as the pill penalty. And so what do we mean when we say the pill penalty? So currently, the IRA allows for small molecule drugs to be eligible for the drug price negotiation program 7 years after the drug receives FDA approval, whereby biologics, those are drugs that are developed based off of like living organisms, they're eligible 11 years after FDA approval. So think about that. So there's a small molecule drug like a pill. They're eligible for the negotiation program after 7 years, whereby biologics are eligible after 11. Why? We don't know why that penalty was, but what we do know is that following the 2-year negotiation period that Kirsten just outlined, small molecule drugs will be subject to drug price negotiations 9 years following FDA approval, and biologics 13 years. And so what the EPIC Act would do is simply amend the IRA to fix that pill penalty that we call it, to give small molecule drugs and biologics parity, meaning that they would both have the same 13-year patent timeline. And so CSC supports this bill because we believe that this bill will actually help to prevent the law's unintended consequences of stifling innovation and increasing logistical burden on people impacted by cancer by ensuring continued research into new treatments and cures for cancer patients. What we also know is that we're beginning to see that more and more cancer drugs are being developed as a small molecule drug. And so we believe that access to small molecule drugs are essential for the treatment of many different types of cancers. And when we also think about this from an access and a health equity perspective, what we have found, there is evidence out there that actually shows that small molecule drugs or oral cancer drugs can improve access to treatment for under-resourced populations by reducing some of those social and logistical challenges of time-sensitive appointments at infusion centers. For example, it's easier, it could be easier for someone to have it in pill form. They can take the medication at home versus having to travel to a center to get their treatment. And so we're thinking about all of these areas when it relates to ensuring that patients continue to have access to treatment. And that's why we support the EPIC Act, because we believe that this improved and enhanced access to small molecule drugs can address many of those health disparities that I mentioned that are present in under-resourced and underserved communities. And we call that an unintended consequence, right, of the IRA. And we weren't in that room, CSC, when these decisions were being made, but we are bringing to light, as part of the patient advocacy community, some of these barriers, or artificial barriers that have been developed that are very real and very important and can serve as a disincentive for someone to receive access to care. And we don't want to disincentivize pharmaceutical companies to continue to innovate in this space, and have these treatments available, considering the prevalence of cancer in the United States, right? We know for 2024 alone that there's projected, according to the American Cancer Society, to be about 2 million new cases or diagnoses of cancer in the United States. And of that, more than 1.4 million are projected to be Medicare beneficiaries, which is what we're talking about through the Medicare Drug Price Negotiation Program. And so just knowing how important Medicare is as a payer for people impacted by cancer, and just for Americans at large, we want to work with Congress, CMS, and other patient advocacy communities and other stakeholders to ensure patients continue to have access to small molecule drugs. I also want to talk about really quickly the other bill I mentioned called the ORPHAN Cures Act. And so we are, CSC, we are a member of a task force called Save Rare Treatments Task Force. And this task force is all about making a very important change or amendment to the IRA. And the Orphan Cures Act focuses on preserving innovation and access to drugs that serve individuals that have rare diseases. And why is this important? This is important because we know that approximately 95% of rare diseases currently do not have any approved treatments. So that showcases the need for continued and expanded research and development. And we definitely don't want to disincentivize that in this space. Remember, we as a patient advocacy community, we're thinking about equity, right? And access. We talked about the EPIC Act and what that means with respect to maybe logistical and some social equity issues. When we talk about the Orphan Cures Act, we're thinking about equity with respect to people who are impacted by a rare disease, knowing 95% do not have approved treatments. And so currently what we know is that the IRA, through the Medicare Drug Price Negotiation Program, included a provision in the law that excludes orphan drugs from negotiation eligibility only when they are designated for a single rare disease or condition, and when the FDA approvals are solely within that designation. So if a drug has been approved for an orphan drug, and orphan drugs are typically defined as it's a rare disease that the population is typically less, I believe, equal to or less than 200,000 people. That typically meets the definition of rare disease, right? And so what CMS is what the IRA is saying is that if there is a drug that serves a population that is determined to be for a rare disease, that indication, that one indication, is excluded from the drug price negotiation program. However, the current IRA orphan drug exclusion policy for that one drug only does not reflect the unmet need for treatment of rare diseases and the unique demands of rare disease drug development. Why? I'm saying this because what the current law is saying is that if that rare disease, that drug for that one orphan drug rare disease, if they decide they want to do additional research and request an approval for subsequent orphan rare diseases, that drug will lose its orphan drug exclusion and will then be subsequent, or not subsequent, but then be eligible to the Medicare Drug Price Negotiation Program, which we believe goes against the purpose of the orphan drug incentives that have been in place by the FDA. So we support the Orphan Cures Act because we believe it's a common sense legislation that would preserve the orphan drug status of medications that treat one or more rare diseases, exempting them from IRA. Remember, right now the IRA says you're only exempt if you treat one rare disease. The Orphan Cures Act will amend it to say treating one or more rare diseases, that drug will continue to retain the orphan drug status and be exempt from the IRA drug price negotiations. And so we believe that this is really important, again, from a data and evidence perspective. What we do know is that of the currently 1 in 5 FDA-approved orphan drugs are also approved to treat additional diseases. So about 20% of orphan drugs are approved to treat additional diseases, and 60% of those secondary indications are for another rare disease. So this is really important. And if we don't make this fix, it could really have some downstream implications on continued and expanded R&D in the rare disease space. And what we do know as a patient advocacy community is that there are reports out there that suggest that the IRA orphan drug carve out, like I mentioned, disincentivizes pharmaceutical companies from wanting to conduct research into secondary indications, because the multiple indications would cause them to lose that orphan status, making them eligible for drug price negotiation. And this is important because we know that greater than 70% of additional indication approvals occur more than 7 years after the initial approval, leaving only 2 years of patent life before price negotiations occur, as the IRA in its current form reduced the effective patent life of small molecule drugs to 9 years. And so what all does this translate to? All of these disincentives and maybe stifled innovation, this can translate into 79 fewer small molecule drugs, fewer than 188 indications. So that means we could lose 79 drugs, lose 188 additional indications, and potentially lose 116 million life years over 20 years. And so what we're talking about, while they may seem like very small technical fixes to the IRA, they have some really important and considerable downstream implications on access to care for people impacted by cancer.
Deneen, that was really, like Kristen, very thorough. And as a patient of color, it is shocking how much policies impacting our healthcare, and people don't know what's coming for them, right? That's why what we do here is so important, getting patients educated about their breast care, but how to interact with policymakers and change things that can impact their lives in a way that could change or end their lives. We have to use our voices to speak up about things that matter to us. So thank you for that, Deneen and Kirsten. To Tamika, and share a bit about, Tamika, your story. And you're a product of medicine getting advanced medications and clinical trials. Can you share a bit about how what you just heard impacts you as a human being and your life in living legacy, and what you want to see change?
Thank you, Mama. Yeah, there is more to the affordable cost or money. Policies limit treatment, as we were discussing, and they slow down the development of new treatments. And for me, living with MBC, that's a problem, because my treatments are consistently changing. My treatments are consistently being new for me and new for others who are MBC or other thrivers. And because of that, that limits us in receiving treatment. And we don't want, that to happen. We need not for that to happen, because we want to live. I know I personally want to live. So we need for the treatments to continually to be developed, and continually to be affordable, and continually to be accessible to us.
Tamika, what would you tell a lawmaker right now if you saw somebody, if you're on the Hill, what would you tell somebody who's supporting the IRA work and the other work that's impacting your healthcare? What would you say to that person?
I would definitely tell them my story, and how how the policies affect me personally, and how down the line it does not only affect me, but it could affect others coming up behind me, or others diagnosed.
Yeah. Yeah, definitely. Because people who are MBC are on lily pads, right? I always say they're on a pad. Here's a pad you're on now. This medication is holding you on this pad. And
Mm-hmm.
once it stops working, it starts to sink. You have to jump to the next pad. If it's not there, you drown. And so for people like you and others watching, even for myself, right? Innovation is so critical for our population. So thank you for
Yeah,
that. Thank you for
no
that.
problem.
You want to share more about your story and what you're doing and how you're advocating to change? Because you're always out there sharing your story. You've been on the hill and you're using your voice and you're being very demure right now and very, very like, but you're epic in your own right. So can you just kind of, like share about how you're acting to change some of these things yourself?
So for me, if I'm always advocating, whether I'm being admitted in the hospital and some things aren't going right, I'm advocating for myself. I'm advocating for new change when it comes to my treatment plan. I love the team that I have. I part of my story is that when I was initially diagnosed with MBC, I had a doctor who just said, "Here, take these chemo pills," and that was that. You know, and I was like, wait a minute, we don't even know if it's still the breast cancer. We don't know anything. We weren't able to gather any information because the biopsy that they did, the lung biopsy that they did was inconclusive. And his attitude towards me being diagnosed MBC was so nonchalant and just so, I mean, just throwing, not physically throwing, but physically saying, here, take these chemo pills, to me was just so not demure.
It's
So it was just, it was just it was like he just didn't care anymore. He just didn't have his bedside manner just went out the window. Right. So I decided to change teams. My thing was I was changing teams to get better access, to drugs and better access to care. And the team that I have now include me in the process of where we're going in my treatment, especially because I am MBC and because things are often changing. And things are often, sometimes I'm good and I can be online with you all and be on a webinar. And then there's other times where I'm in the hospital because the meds are not working anymore or the pain is too severe. So we really want to make sure that with these policies, we're not slowing down health equity. You know, it needs to continue. It doesn't need to stop. It doesn't need to slow down because we have individuals that want to continue with care and individuals that need care and that need the access to the drug. So, if we stop advocating, if I stop advocating, right, no one's going to continue to hear the voice. We need to continue to make sure that our voices are heard.
definitely. I mean, I will say this now, Tamika. Thank you. You're extraordinary to me. Just how you live your life and how you push through for equitable access for other people and for yourself. And it's changing people's lives every day. I see it through the feedback I'm getting from
Oh, thank
Michelle's, many other people. As you know, we lost a patient this Monday, and it's been a week,
Yeah,
and but you know why she's not here is the medication didn't get to her the right medication in time. And so we're talking about people's lives here, not just a policy. When I
right.
hear policy change affecting a patient's life, it breaks my heart because that's somebody's sister, mother, daughter. And at Tigerlily, we are close to our patients. They become our friends, our sisters. We talk, we text, we engage. I meet their daughters and families, and this is not a job for us. This is our heartbeats. And
Yes,
so it's important to realize that you're not treating a number, you're treating a person, a human being that deserves to live a life and have equitable access to medications she needs to extend that life,
right.
and enjoy her life as well. Um,
Right.
Tamika, I was with you. You were at the Empower Ball recently, and seeing your daughter London with you, and it just brought me such joy. I was in tears, and seeing Michelle and her daughter Offset, and so many others. Like we want that longevity for you guys with your families, and that's why we all fight so hard and fast and feel so much for this work, and want to bring our faces and voices to make things different for others now and in the
Yeah.
future.
And we know that, there are fixes available. There are things available. And the Orphan Act and the Epic Act are examples of that. And we just have to continue to push forth and advocate, writing letters, making sure that our voices are heard on the Hill and beyond,
On
so
social
that
media.
we can continue to get the access to care that we need.
Speaking of which, Dr. Shepard, you are also a patient. You're a two-time cancer survivor and a warrior and a baddie and a researcher. You do all the things. I've known you for I don't know what, 15, 16 years.
Yeah,
Um,
yeah.
and before you were a patient, actually, you became a patient twice since I've known you. But I applaud your work in so many ways. And tell me what you've heard, how this impacts you from your work, being a health equity researcher, disparity researcher, and how can these policies impact us negatively? But how can we all collectively on this webinar, those who are watching live and later on as a recording, make a difference with advocating for policy change?
Absolutely. So, we often say in research that today's research is tomorrow's cure. And when we think about that, no matter how great the cure is, the pill is, if it can't get to the populations that need it, or if you've got this great discovery, but it doesn't treat the cancers that people tend to die from the most, then it's not worth it. And so I think when we think about equity, it doesn't just have one face. Sometimes the face of equity is a racial ethnic group, sometimes it's geographic where you live, and sometimes it's the disease that you were diagnosed with. And so when we think about this advocacy piece, research is a part of that, right? So there's the pipeline of what's developed. We think about tamoxifen, which initially was created as a contraceptive that was repurposed. And as a result has led to reductions in recurrence and improvement in mortality, improvement in survival. And so we think about the possibility that elderly who tend to be diagnosed with comorbidities, so they also face adverse outcomes from their cancers when diagnosed. African Americans and others of color tend to have more comorbidities. So again, we may focus on the one disease, but there are all these other things that patients experience. And so the idea of making sure that we advocate for information so that patients, their caregivers, and families know what's coming. And then the question, when we think about these policies, sometimes we're not in the room. What's the research that is supporting that? What is the research gap? And a lot of individuals sort of in the school that I'm leading now, they do these sort of policy analyses, right? And so we have tools that we can look at potential impact, as we heard earlier from Kirsten, but how is this being funneled and disseminated to our patients and even the provider community? So from my perspective, thinking about the importance of patient-centered policies. So we want to have patient-centered research where we're not just involving people in clinical trials. I will say we need to increase the diversity in clinical trials. We don't want to create any disincentive for our pharmaceutical manufacturing companies to not focus on certain diseases. We talked, or think about triple negative breast cancer. We need more discoveries there, right? We need more targeted therapies, and as well as metastatic disease. So we have this issue that could come up where we are now exacerbating the equity that already exists, with availability and affordability. And so we want the patient voice in that research process. We do want to have our diverse patient populations involved in the research, because that's important to know that these drugs that are being developed are effective for them. And then we also want to make sure that we're having the patient and caregiver voice in informing how we should prioritize it. And so I think these partnerships between Tigerlily, our supportive community, and our research community. Yes, pharma, but also some of our public institutions can really help to make sure that we have this balance of affordability and then incentivizing innovation. And then my question is, when we talk about affordability, to whom are we referring? Right? Are we talking about the patient out-of-pocket costs, or is it someplace else in that system? So again, from my perspective, being sure that we give access to the information that's needed, so that we can be advocates, and that we can reduce the disparities that already exist and that we don't exacerbate them.
Thank you for that. And you've always been an extraordinary ally to me. When I first began Tigerlily, I remember I would call with questions about policy work and advocacy. You were at our first Hill Day in 2009, you know? And so this work requires all of us bringing our hearts and our passion to it. And nobody's better than the other, or whether it's a degree or not. You never said to me, oh, you're only a patient. You said, what do you need? How can I support you? And that support is what got me to further my work on the Hill and policy. And now I've worked on over, I don't know, 40, 50 different bills and legislation over the past, close to 20 years. So thank you for all of you, Deneen, Kirsten, Tamika. We are up against time. I'm going to have the Oscar Kane pulling me off the stage very soon. So in like 20 seconds, just one last word from each of you. Just what would you want as one phrase that you want to hear about the impact of this work and how we can create change from a research perspective, policy, patient, and patient advocacy group. We'll start with Vanessa Shepard because she had the last word, and you got cut short. So we'll start with you, then go to Deneen and Kirsten, and end with Tamika.
I would just say hold us researchers accountable for what we do. Make sure that we think about the policy impact of all of our work, whether it's my personal research. At the end of the day, this is not hypothetical. This is indeed people's lives. So hold us accountable for considering our impact when we go about our research.
Thank you. Thank you. Deneen?
Yeah, I would say your voice matters, and that your perspectives are so critically important when speaking with your lawmakers at the federal level or back at the state level. Let them know how these legislations impact your community, right? That might be different from experiences that they hear, and why this is so important to you. This is something that's typically said in the disability community, but I agree, nothing about us without us. And so that's what I would leave for everyone.
100%. Kirsten Axelson.
Just to remember that the Inflation Reduction Act can be fixed and drugs can be affordable. It is a fallacy that you couldn't enact some things like the EPIC Act or the change to the orphan drug definition and not retain some of the provisions that make drugs affordable.
And thank you for that. And now to our MVP, Tamika.
I really just put it in the chat. We have to just continue to mobilize, continue to share on social media, write letters, and connect with organizations like Tigerlily, the Bretsies, MDC Alliance, and Metaviber. We have to continue to just let our voices be heard, and not stop.
Yeah, so through patient story sharing, like Tamika's story being shared, we have people that share stories all the time. Members, offices, social media activations as well. We do letter writing. You can go to our website. We have a whole portal. You just plug your name in there, your email address. It goes to the member. We have it already crafted for you. So patient story patient story sharing, social media activation, letter writing as well. Meeting your members of Congress in person, we can help you with that too. We can go there with you, hold your hand, or do it virtually, but you can use your voice to make a change. When I began this work, I was just a little babe, had no idea what I was doing, but I had my passion and I had a firm belief in doing what was just, what was right. So we have a whole toolkit we can send you guys after the webinar to help you navigate your policy activation. If you want to do it alone, you can, but we just want to work with you on this. So just partner with us, and you are the change in the world that we want to see. So please get busy, get acting, and we're happy to have all of you be here. And then last but not least, I want to honor Catherine in this moment. Catherine is a wonderful angel in heaven now, but she has been a tremendous inspiration to me as a human being and a leader, and to all of you. So let's carry her legacy forward for herself and her daughter, because she did so much to make change in this space. And so she's only in transition right now, but she's in heaven watching all of us. We're going to carry her voice and her mission forward. So thank you all for all you do, all this work together, the allyship in research, in patient advocacy policy work, in policy work, in patient advocacy. It all matters. It keeps us here longer, better quality of life. And begin to act to make more change to increase life for people who need it, like Tamika and Michelle and Catherine and so many others. Thank you for your time and resources, and we were blessed to be able to share this time with all of you today. Thanks to our sponsors, Gilead, Amgen, Merck, AZ, Lilly, Pfizer, and Pharma for their support. We couldn't do it without any of you, but thank you all for your support. Thanks to our panelists, you're amazing, and our attendees, we love all of you guys, and I will see you soon. Much love and blessings, and take care of yourselves, okay? Much love.